Welcome to the funnel effect. We are diving deep today into a topic that honestly is rapidly redefining advanced cardiovascular care, tricuspid regurgitation, or TR. Now, this is a condition that for decades was sort of pushed to the background, wouldn't you say?
Absolutely. It was often seen as a secondary consequence, almost an afterthought to left-sided heart problems.
But the sheer number of patients it affects, and frankly, the severity of its impact, well, that's pushed it right into the spotlight, especially with all the innovation happening now. Our source material for this deep dive is a really comprehensive piece, a state-of-the-art review. It's titled Current Evidence on Tricuspid Regurgitation Interventions in Heart Failure. And we should credit the authors, Rebecca T. Hahn, Mariana Adamo, and Neil P. Pham. This was published in a leading journal, JACC, Heart Failure, Volume 13, Number 8, from 2025. So our mission today really is to cut through some of the complexity here and understand the latest clinical thinking. Because TR is not some niche problem, is it?
Not at all. It's incredibly common, devastatingly so, in advanced heart failure, or HF. It dramatically impacts quality of life and, crucially, survival.
Right. And we need to look at the data that's driving this big shift we're seeing, away from, well, historically pretty poor medical management,
Often just diuretics, really.
towards these brand new, high-tech transcatheter treatments,
Yeah.
TTVI, as they're known.
And what's fascinating as you dig into this review is that the main takeaway isn't just that TR is bad. We kind of knew that. The real eye-opener is how prevalent and how deadly moderate or severe TR actually is. It's really demanding this rapid evolution in how we treat it.
Because medical therapy alone just wasn't cutting it for many patients.
Exactly. It often fails them. So we're seeing this huge shift towards these, high-tech interventions. But, and this is the core challenge for every heart team, the big question remains, when? When should we actually step in? Is there a perfect window? Early enough to make a difference, but not so early that it's unnecessary.
That timing conundrum, that's what we really need to unpack today. Okay, let's start with the numbers, because they really hammer home the urgency here. This isn't rare. Moderate or severe TR, the review says, affects somewhere between 10% and maybe 23% of all chronic heart failure patients. That's already a lot.
It is, but then look at the patients with more advanced symptoms.
Yeah, the numbers jump dramatically.
They soar, over 50% in those advanced cases. That jump is really the key indicator. As the left side of the heart fails more, the burden shifts, it falls onto the right side, and that just makes the TR worse.
And the data on survival.
It's unforgiving, stark, really. Regardless of anything else, other conditions, age, as the TR gets more severe, survival gets progressively worse. It's a direct link.
Once the right side starts to really fail because of that leaky valve,
Yeah,
the prognosis tanks.
it plummets, yeah.
Now, cardiologists often talk about heart failure in two main buckets. HFrEF, that's reduced ejection fraction, a weak pump, and HFpEF, preserved ejection fraction, where the pump muscle is stiff but technically strong. Does the source tell us if one group gets severe TR more often?
It does, and it's a pretty significant difference. TR is about twice as frequent in patients with HFpEF. The review pegs it at 52% prevalence in HFpEF.
Wow, 52%.
Compared to 26% in HFrEF patients.
Okay, so that helps frame who we're often dealing with in these intervention trials.
Exactly. If you look at the big trials like Triluminate or Trisynthectin, the patient profile often mirrors this HFpEF picture. They tend to be older, often female, frequently have atrial fibrillation AFib,
Right.
and signs of diastolic dysfunction, that's stiffness. So it's important to realize that a lot of the evidence we have for these new transcatheter valves, the TTVI, is being generated in a group where the main issue might be more about volume overload and the atrium stretching, rather than just pure right-sided pump failure itself.
That makes sense. Okay, let's translate that failure, that leaky valve, into what the patient actually feels. The symptoms of right heart failure, RHF, caused by bad TR. It starts with fluid retention, right? Systemic fluid backup.
Because the tricuspid valve isn't closing properly, blood flows backward into the veins instead of forward to the lungs.
And the classic signs. You see it in the neck veins first.
Often, yes. Elevated jugular venous pressure, those visibly distended neck veins. Then it progresses downwards. Peripheral edema, so swelling in the legs and ankles.
And then fluid in the abdomen, ascites.
Yes, ascites. And that's not just uncomfortable swelling, it causes real problems. Painful liver congestion, what we call hepatic distension.
And it messes with absorbing nutrients and meds.
Critically, especially oral diuretics, the gut is too swollen and congested to absorb them properly, so the patient takes the pill, but it doesn't get into the system effectively.
And if it gets really bad,
You can end up with anasarca that's severe, widespread body swelling, just fluid everywhere.
So as the right heart continues to fail under this load, the patient's overall condition just spirals downward. The RV, the right ventricle, loses its pumping power.
Its capacity diminishes, yeah. You get decreased systolic reserve, chronically low cardiac output.
And what does that low output mean in daily life? What does the patient report?
That's the profound exercise intolerance, crushing fatigue, and dyspnea, shortness of breath, even with minimal exertion. It severely limits everything they do.
And if this chronic RHF just goes on and on, unchecked.
The systemic consequences are devastating. We're talking severe malnutrition, sometimes called cardiac cachexia, where the body wastes away. Anemia is common. Reduced cognitive function, sort of a brain fog from poor blood flow.
And eventually organ damage.
Yes, the end-stage damage. Cardiohepatic syndrome affecting the liver and cardiorenal syndrome damaging the kidneys. This creates a terrible vicious cycle of more congestion leading to more organ failure, which causes more congestion. It's very hard to break. So to even begin treating this effectively, we need to classify it correctly. And the review makes a strong case that the old way, just primary versus secondary TR, isn't really enough anymore.
Primary meaning the valve itself is diseased. Secondary meaning it's stretched due to other heart problems.
Right. But secondary TR is the vast majority, maybe 90% of cases. And it's not all the same. We need a more nuanced system.
Okay, so how does the modern classification break down secondary TR?
The crucial refinement is splitting secondary TR into two main types, based on where the problem originates. There's atrial secondary TR or ASTR.
A for atrial.
Exactly. This is often linked to that HFpEF profile we talked about. The main driver is atrial enlargement, particularly the right atrium, and dilation of the tricuspid annulus, the ring the valve sits in. Often, in ASTR, the actual right ventricle function might still be preserved or only mildly impaired initially.
Okay, so ASTR is more about the atrium stretching the valve ring.
In many cases, yes. It's often driven by high atrial pressures, like you see in long-standing AFib or diastolic dysfunction.
And the other type, VSTR.
V for ventricular. Ventricular secondary TR or VSTR. This is usually the more challenging one.
How's that?
Because VSTR is typically linked to HFrEF, that weak left pump, and critically severe RV dysfunction itself. The anatomical issue here isn't just annular stretch, it's leaflet tethering.
Tethering.
Yeah, the right ventricle wall stretches and remodels. It pulls down on the chordae tendineae, the little strings holding the valve leaflets, and this pulls the leaflets downwards, deep into the ventricle, preventing them from coapting properly in the middle.
Ah, so they can't close the gap because they're being pulled apart from below.
Precisely. This severe leaflet tethering makes it anatomically much, much harder for repair devices like the edge-to-edge clips, T-ear, to grab the leaflets and bring them together effectively.
Oh, got it. So ASTR, often atrial-driven, may be more amenable to fixing the annulus or reducing pressure. VSTR, ventricular-driven, involves deep remodeling and tethering, inherently riskier and harder to fix anatomically.
That's a good summary. And then there's a third category we absolutely have to recognize, the CID factor.
CIE, cardiac implantable electronic devices, pacemakers, defibrillators.
Exactly. TR associated with those leads. This affects a significant chunk of patients, maybe 10–15%.
How do the leads cause TR?
It can happen in a few ways. The lead might physically cross the valve and impinge on a leaflet, trapping it or causing damage so it can't close. Or sometimes the TR was already there, but the presence of the stiff lead just makes it worse, preventing proper closure.
And does it matter how the lead causes it?
From an outcome perspective, maybe not. The bottom line is the presence of a CIE lead interacting with the valve significantly worsens the overall prognosis for that patient. It complicates everything.
Okay, so with these different types, ASTR, VSTR, CIED related, does the natural history differ? Does one group generally do worse?
The available data suggests that generally outcomes are worse for patients presenting with that VSTR phenotype.
Because it signals deeper RV damage.
Exactly, because VSTR is intrinsically tied to severe, often primary RV dysfunction, and that irreversible anatomical change, the tethering, it's just a much more ominous sign than ASTR, which might be more related to reversible factors like atrial pressure or volume overload.
Which brings us right back to risk stratification. If this disease progresses so badly, especially VSTR, how do clinicians decide who needs aggressive intervention now versus who might wait or just get medical therapy?
This is where risk scores become absolutely critical. The review highlights several that have been developed specifically for severe TO patients who are initially managed conservatively, meaning without immediate surgery or TTVI.
Like the Hochstadt model.
Yes, that's one example. There are others, like single-center clinical scores. What they do is take multiple factors, lab results like kidney and liver function, echo findings like RV size and function, clinical symptoms, and combine them into a single score
To predict.
to predict the risk of dying within 1 year, all-cause mortality.
And these scores work. They're predictive.
They are remarkably predictive. Their value isn't just confirming that, sicker patients do worse. They provide objective, quantifiable data showing that as the risk score increases, the mortality rate climbs drastically.
So they really illustrate the danger of waiting too long.
Precisely. They powerfully show the risk of late referral. When the score is already high, the patient may have missed the window for effective intervention. These tools are essential for having realistic conversations with patients and avoiding the path towards futile, high-risk procedures when the systemic damage is already too great. So, before we even think about devices or surgery, the absolute foundation is optimal medical therapy, OMT. We have to stress that no intervention is likely to succeed long-term if the underlying medical issues aren't aggressively managed.
Right. It's not just about fixing the valve leak in isolation.
No, not at all. The medical strategy here really has two main goals, two pillars.
Okay. Pillar number one.
Pillar one is correct the predominant cause. Since most TR is secondary, often to left-sided heart failure, the first step is aggressive guideline-directed medical therapy, GDMT, for that left-sided HF.
And that means using the best drugs we have for HF.
Absolutely. And the review specifically mentions the newer classes that seem to have benefits beyond just the left ventricle. For instance, sacubitril valsartan Entresto isn't just for HFrEF. Studies suggest it can also reduce pulmonary hypertension and improve right ventricular performance.
Which would take strain off the tricuspid valve.
Exactly. It indirectly helps the TR.
What about the SGLT2 inhibitors? Those have been game changers for HFpEF and HFrEF. Do they help the right side too?
They seem to. The evidence is building that SGLT2 inhibitors offer benefits for the right ventricle as well, possibly by reducing fibrosis and improving overall hemodynamics, and that's independent of just making people pee more.
So treating the underlying HF is a form of TR therapy.
It definitely is. And the review mentions a pretty striking statistic. About 50% of patients who get a transcatheter mitral valve repair fixing the left-sided mitral valve actually see their TR severity decrease automatically soon after.
Wow. Fix the left side, and the right side often improves on its own.
It can. It highlights how interconnected everything is.
Okay, so that's pillar one. Treat the underlying cause. What's pillar two of medical management?
Pillar two is decongestion, getting rid of that excess fluid. But as we discussed, this gets really challenging in advanced TR because patients often become resistant to standard diuretics.
Right, you mentioned the gut absorption problems and kidney issues.
Exactly. Managing fluid becomes incredibly difficult due to 1. Chronic renal congestion impairing kidney function, 2. Malabsorption of oral diuretics because of gut edema, and 3. This phenomenon called distal increased sodium avidity.
Meaning the kidneys desperately try to hold on to salt and water.
Yeah, even though the patient is overloaded, the kidneys sense low effective circulating volume because of all the backup, so they fight the diuretics. To overcome this, clinicians often have to resort to using combination diuretics.
Like adding a thiazide diuretic to a loop diuretic.
Precisely. Like adding metolazone or thiazide to furosemide to block sodium reabsorption at multiple points in the kidney. Sometimes they even need intravenous diuretics or, in extreme cases, ultrafiltration to physically remove the fluid.
It sounds like a constant battle against fluid overload.
It absolutely is for these patients.
Let's shift gears slightly. Atrial fibrillation AFib. You mentioned it's really common, up to 50% prevalence. Is there a strong case for aggressively trying to get patients back into normal rhythm control?
Well, the data is mostly retrospective, not from big randomized trials specifically for TR, but it's compelling.
What does it suggest?
It suggests that rhythm control strategies, things like catheter ablation for AFib or even just timely cardioversion, are associated with improvements in TR severity.
How would that work?
The thinking is if you restore a normal coordinated atrial contraction, you reduce that constant high pressure and stretch in the right atrium that drives the ASTR type of regurgitation. It might allow the valve annulus to shrink back a bit.
So the source suggests maybe getting rhythm under control first.
It implies that early rhythm control might be a really important, maybe even prerequisite step before you jump to a valve intervention, especially for ASTR. It could potentially stabilize or even improve the TR on its own.
Okay, and what about those tricky CIED leads the pacemaker wires causing TR? How do you manage that?
That requires a very specialized approach. It's definitely not a job for one doctor. It needs a dedicated multidisciplinary heart team, electrophysiologists, surgeons, imaging specialists, HF docs.
Because extracting the lead is risky.
Extremely risky.
Yeah.
You're weighing the potential benefit lead extraction can reduce TR severity in maybe up to a third of carefully chosen patients if the lead was the main culprit.
Oh.
But the risk is substantial. The extraction procedure itself can actually worsen the TR in up to 25% of cases. You can tear or damage the delicate valve leaflets trying to get the lead out, especially if it's been implanted for a long time and is scarred in.
So if extraction is too risky or it doesn't work,
then you're often left looking at transcatheter options, TIR or TTVR, to try and work around the lead or address the damage it caused. It's a complex decision tree.
this brings us to something you hinted at earlier, this idea that some TR to TIR gets better on its own with medical therapy, the regression conundrum.
Yes. This is a crucial point and a real headache for designing clinical trials.
How often does severe TR actually regress just with meds?
The evidence is surprisingly strong. If you look at the control arms, the patients who got only OMT in the big TTVI trials like Triluminate Pivotal,
What do they find?
more than 20% of those control patients who started with severe TR had spontaneously improved to moderate or even mild TR by the follow-up time points.
1 in 5 got significantly better without a device.
At least 1 in 5. Other studies mentioned in the review show regression rates even higher, sometimes up to 38%.
Why does that happen?
It often happens when the medical therapy is truly optimized. Effective GDMT improves cardiac function. Aggressive decongestion reduces the volume overload and the pressure on the right side. The pulmonary pressures come down, and the tricuspid annulus might just shrink back enough for the leaflets to co-opt better.
And the implication for trials is?
It's huge. It creates a real lack of equipoise. Equipoise is that state of genuine uncertainty about whether a new treatment is better than the standard one. How can you ethically randomize a patient to an invasive procedure with known risks, even if small, when there's a pretty decent chance, maybe 20–30%, that they might get substantially better just by optimizing their medications?
So these patients who regress spontaneously, they represent a group where intervention is likely unnecessary, or at least could be safely delayed.
Exactly. Identifying them prospectively is a major challenge. Otherwise, we risk intervening on patients who would have improved anyway, making the intervention seem more effective than it truly is for the population that really needs it.
Okay, so medical therapy has its limits, and sometimes it even works surprisingly well.
Yeah.
But historically, before TTDI, the only definitive treatment was surgery. Yet, isolated tricuspid valve surgery, ITVS, has some pretty sobering outcomes mentioned in the review. Why is operating just on the tricuspid valve considered such a high-risk gamble?
It really comes down to a tragedy of timing, unfortunately. The data shows that ITVS carries really high in-hospital mortality rates, somewhere in the range of 7% and 9%.
1 in 10 to 1 in 14 patients not surviving the hospital stay.
Yes. And the morbidity, major complications like severe bleeding, kidney failure needing dialysis, prolonged ventilation, stroke that can be as high as 30%.
Why are the numbers so grim?
It's almost entirely attributable to late referral. By the time patients are considered for isolated tricuspid surgery, meaning they aren't already having other heart surgery like mitral or aortic valve replacement.
Which is the more common scenario for TV surgery, right? Done concurrently.
Exactly. Most TV surgery happens alongside left heart procedures. Only about 15% of all TV surgeries are isolated ones. And the patients who get referred for isolated TV surgery are typically very far along in their disease process.
So
They're often elderly, very frail, frequently malnourished, and critically, they already have significant end organ damage, that cardiorenal syndrome or cardiohepatic syndrome we talked about. Their bodies just don't have the reserve to withstand a major open heart operation.
So the surgery itself might be technically feasible, but the patient is too sick to tolerate it.
That's often the case. And the current guidelines reflect this caution. The main class I recommendation from the ACHA for ITVS is really limited, basically. Only consider it if the patient is already undergoing left heart surgery for other reasons.
There just isn't strong data supporting isolated surgery for these high-risk patients otherwise.
We lack robust evidence showing a clear survival benefit for ITVS alone in that typical late-stage high-risk population.
Okay, so given that risk is so heavily tied to the patient's underlying condition and organ damage, how do surgical teams decide who might actually be a candidate? They must rely heavily on risk scores again.
Absolutely. It's a multi-layered assessment. They'll start with general cardiac surgery risk models like the Euroscore 2, which gives a baseline prediction for any major heart operation.
But that's not specific to TR, right?
No, it's general. So because right heart failure and congestion are so central to TR, models that incorporate liver and kidney function are critical. Teams increasingly use scores like the Mellitus score model for end-stage liver disease, originally from liver transplant or MELD albumin.
Because bad liver and kidney function are such strong predictors of poor outcomes after surgery.
Extremely strong. They quantify that systemic damage we keep mentioning.
But the review highlights a specific score for TR surgery, the TRI-score.
Yes, the TRI-score is probably the most important specialized tool here. It was developed specifically to predict in-hospital mortality after isolated tricuspid surgery.
What kind of factors does it include? Is it complex?
It uses 12 preoperative variables, things you'd expect like age over 70, severe symptoms, NYHA class 3 or 4, having chronic lung disease, being on high doses of diuretics.
Okay, markers of general frailty and HF severity.
Right. But crucially, it also includes objective measures of that systemic organ failure. Things like severe kidney dysfunction measured by high creatinine or low eGFR, and signs of liver impairment like low albumin or high bilirubin.
So it really captures the multi-organ impact of chronic severe TR.
It does, and it's highly predictive.
So what's the practical implication? Is there a TRI-score cutoff that tells you surgery is probably a bad idea?
Yes, the score defines the therapeutic window with, frankly, chilling clarity. Patients with a low TRI-score, say less than 4, tend to be those referred earlier before the irreversible organ damage sets in. These patients can benefit from surgery, and valve repair is generally preferred over replacement if anatomically possible.
But if the score is high?
The analysis cited in the review shows pretty clearly that intervention provides no clear benefit, maybe even harm, for patients with a TRI-score of 6 or greater.
6 or more is the point of futility.
Essentially, yes. At that point, the systemic disease, the frailty, the organ damage are just too advanced. The very high risk of the operation itself outweighs any potential benefit from fixing the valve. The horse has already bolted, so to speak.
So surgical reality is, ITVS is really only a viable option for a very select group.
Highly selected. Younger patients, lower risk profile based on TRI-score, treated relatively early before that irreversible cardiorenal and cardiohepatic damage. For the vast majority of patients presenting late with severe symptomatic TR, the surgical door is effectively closed.
Okay, so surgery is out for most patients who present late with severe TR. That explains the explosion in transcatheter tricuspid valve intervention, TTVI. The source says over 25 devices are being studied. That's incredible growth.
It is, and it's entirely driven by that huge unmet clinical need. These are patients who are symptomatic, have poor quality of life, poor prognosis, but are deemed too high risk for surgery. TTVI offers a minimally invasive alternative.
And the variety of devices?
Right.
Why so many different approaches?
It reflects the complexity and variability of the tricuspid valve itself and the ways it fails. Unlike the mitral valve, which is mostly 2 leaflets, the tricuspid usually has 3, sometimes more, and the anatomy can be really challenging.
Different shapes, different sizes, different problems.
Exactly. You have annular dilation where the valve ring stretches. You have the leaflet tethering we discussed in BSTR. You might have flail leaflets or leaflets damaged by leads. So different devices are designed to tackle these specific anatomical problems. Some clip leaflets together, some reshape the annulus, some replace the whole valve.
So what are the main types of devices that are actually approved and being used now, based on the review?
Broadly, they fall into 2 main categories currently available in the US or Europe. First, there's transcatheter edge-to-edge repair, or TEER.
Like MitraClip for the mitral valve, but for the tricuspid.
Precisely the same principle. Devices like TriClip and Pascal use clips delivered via catheter to grasp the tricuspid leaflets and pull them together centrally, reducing the regurgitant gap.
Okay, TEER is repair. What's the other main category?
The other is transcatheter tricuspid valve replacement, or TTVR. This involves delivering a whole new prosthetic valve via catheter and deploying it within the native tricuspid valve position. The EV-OAK system is the main example mentioned as approved.
So, clip repair versus full valve replacement, both done percutaneously.
Correct.
Let's dive into the big randomized trials for these. Triluminate for TEER, Trisend the second for TPVR. What's the most striking finding about their primary endpoints? How do they define success?
This is absolutely critical to understand. All the major TTVI trials primarily met their main goals by showing dramatic, statistically significant improvements in quality of life.
Not mortality. Not hospitalizations.
Not as the primary endpoint, no.
Yeah.
They used the Kansas City Cardiomyopathy Questionnaire, the KCCQ score, which is a very well-validated tool measuring symptoms, function, and quality of life from the patient's perspective, and the improvements were huge.
So the main proven benefit initially was making patients feel significantly better.
Undeniably, that was the primary win.
Okay, let's break down the TIER trials first. Triluminate, Pivotal, Tri-Orifar, what do they show?
Both trials clearly met their primary endpoints, showing significant benefit for TIER over medical therapy alone. The win ratios were 1.48 and 2.08, heavily driven by those KCCQ score improvements.
How much did the scores improve?
Quite substantially. We're talking average improvements of 12 to 14.5 points on the KCCQ scale. That's considered a very large and clinically meaningful change. Patients really felt better.
And safety. How did TIER fare?
Very well. TIER demonstrated an excellent safety profile in these trials, with low rates of major complications. And it was effective at reducing the leak. It successfully got the TR down to moderate or less in about 89% of patients.
But the impact on death or hospitalization?
That's the crucial caveat. At the initial one-year follow-up, there was no significant difference in the hard endpoints. All-cause mortality or heart failure hospitalizations between the TIER group and the optimized medical therapy group.
So initially, a purely symptomatic benefit despite good TR reduction.
Correct. However, it's worth noting the later data. The 2-year follow-up from Triluminate Pivotal did show a positive signal. There was a statistically significant reduction in the annualized rate of heart failure hospitalizations.
So maybe a longer-term benefit in keeping people out of the hospital starts to emerge.
Possibly. It suggests that while it might not impact early mortality, reducing the like burden with TIER could potentially lessen the frequency of HF exacerbations over time. Still needs more data, but it's promising.
Okay, now let's contrast that with TTVR, the replacement strategy, studied in TRISCEND II, with the EVO key valve. What did that show?
TTVR, as you might expect from replacing the whole valve, achieved stunning anatomical success. It was superior in reducing the TR.
How much better?
It reduced the TR severity to mild or even less in an exceptional 95.3% of patients treated with EVO key E. That's near complete elimination of the leak.
And the KCCQ scores?
They reflected that anatomical success. TTVR led to the highest average KCCQ improvement seen across any of the major trials, an average jump of 17.8 points. So maximum leak reduction translated to maximum symptom improvement.
But you hinted earlier that efficacy came at a cost.
It did. That superior efficacy came with a clear, significant safety penalty compared to medical therapy. TTVR, being inherently a bit more complex than clipping leaflets, carried excess procedural risks.
Like what specifically?
Two main things stood out. Severe bleeding was significantly higher, 15.4% in the TTVR group versus just 5.3% in the control group.
And the pacemaker issue.
That was the other major finding. The rate of needing a new permanent pacemaker after the procedure was dramatically higher with TTVR. 17.4% required a pacemaker compared to only 2.3% in the medical therapy group.
Wow. Almost 1 in 5 patients needing a pacemaker after TTVR. This is a huge trade-off for quality of life.
It's a major consideration. That high pacemaker rate fundamentally changes the risk-benefit calculation for TTVR. It means patient selection has to be incredibly careful. You need to be sure the severity of the TR and the potential quality of life gain justifies that substantial risk of needing a lifelong pacemaker, along with the higher bleeding risk.
So putting it all together, if a heart team is looking at a patient, how do they choose between repair and replacement TTVR? Anatomy seems key.
Anatomy is absolutely central, along with the patient's overall risk profile. The main goal for efficacy is the same for both. Get the residual TR down to moderate or mild, or ideally even less.
But TIER is preferred if the anatomy allows.
Generally, yes. TIER is often considered the first-line strategy if the patient's anatomy is favorable. That means things like having the leak originate centrally between the leaflets, having enough leaflet tissue to grasp, and not having a massive coaptation gap or severe tethering. It's the lower-risk approach.
And TTVR is for the tougher anatomies.
Correct. TTVR becomes the primary option when TIER is unlikely to succeed due to unfavorable anatomy, like those VSDR cases, with severe tethering, very large gaps, short leaflets, or significant leaflet destruction perhaps from a previous lead.
But even then, it's not automatic.
Definitely not. Even if the anatomy dictates replacement, the patient factors weigh heavily. Can they tolerate long-term anticoagulation, which is often needed with prosthetic valves? And critically, is their baseline RV function strong enough to handle the implant?
Why is RV function so critical for replacement?
because suddenly eliminating severe TR by putting in a new valve imposes an abrupt change in load on the right ventricle. If the RV is already severely dysfunctional and barely coping, the sudden change can sometimes precipitate acute right heart failure right after the procedure. So patient selection for TTVR is extremely precise and individualized. So we have these amazing new tools, TEER and TTVR, that clearly help symptoms. But the whole field, as the review points out, is still hampered by some pretty significant foundational knowledge gaps, especially around measurement.
We still can't reliably measure TR severity.
It's much harder and less validated than measuring leaks on the left side, like mitral or aortic regurgitation. Echocardiography, our main tool, is very operator dependent, and the quantification methods aren't as robust. Different centers, even different techs, can get different results for the same patient.
And assessing the RV function itself is also tricky.
Very tricky. The RV has a complex shape, and again, our metrics for quantifying its function aren't perfect. We lack widely agreed upon, consistent cutoffs to accurately grade how severe the RV dysfunction is in these TR patients.
Which is a huge problem, because RV failure is what ultimately determines their long-term outcome, right?
Exactly. We know RV failure is the key prognostic factor, yet we struggle to measure its health accurately and reliably across the board.
So if human eyeballs and standard echometrics are falling short, what's the potential solution? The review mentions technology.
Yes, there's a lot of hope pinned on artificial intelligence and machine learning. AML is already being explored quite actively to try and standardize and improve diagnostic accuracy.
How could AI help?
In several ways. For instance, AI algorithms could potentially automate the 3D quantification of regurgitant volumes from echo, taking operator variability out of the equation. Machine learning could help standardize 2D measurements of RV size and function.
And maybe even predict risk better.
That's another major goal. Developing AI algorithms that can integrate multiple clinical factors, lab values, and complex echo parameters to provide a more objective and accurate prediction of mortality risks or likelihood of benefiting from intervention. The hope is AI can bring consistency where human assessment currently struggles.
Okay, so better measurement is needed. But that brings us right back to the core dilemma we started with, that timing conundrum. Defining the sweet spot for intervention.
Right. The randomized trials, by focusing on KCCQ and showing limited early impact on heart endpoints, have kind of created this clinical trap.
How so?
Well, if we intervene too early, based mainly on symptoms or moderate TR, we achieve great symptom relief, yes. But we expose the patient to the costs and potential risks of a procedure without a proven survival benefit, and we might be treating some of those patients who would have regressed anyway with just OMT.
But if we wait too long?
If we wait until the patient is clearly deteriorating, has severe RV dysfunction, maybe hits that tri-score of 6 or more, then the intervention is likely futile. The systemic damage is done, the RV is too far gone, and fixing the leak at that point doesn't change the outcome.
That point about the tri-score of 6 or more, meaning futility. That must be an incredibly difficult conversation for doctors to have with patients and families who are desperate for hope.
It is one of the hardest conversations in cardiology, telling someone that even though there's a technology to fix the valve, applying it now won't actually help them live longer or better because the underlying process is too advanced.
So, based on current data registry data, maybe some propensity-matched studies, what's emerging as the likely optimal window, that intermediate stage.
That seems to be where the thinking is heading. The data suggests the best chance to see a real prognostic benefit, not just symptom relief, might lie in intervening during an intermediate phase of the disease.
And how would you define that intermediate phase?
It might correlate roughly to a tri-score in the range of, say, 4 or 5. This is likely before the cardiorenal or cardiohepatic syndromes are fully entrenched, when the RV still has some reserve, maybe mild to moderate dysfunction, but hasn't reached that point of irreversible failure.
So intervene before the tri-score hits 6, but perhaps not when it's very low either, unless symptoms are unbearable.
That could be the emerging paradigm. It's intervening just before the cliff edge, when the RV might still recover function once the volume overload from the TR is relieved. That's the stage where we might finally see those massive quality of life gains translate into better long-term survival and fewer hospitalizations.
To actually prove that, though, we need different kinds of trials.
Exactly. We need more pragmatic trials focused on hard clinical endpoints. The review mentions one called Tricuspid-HF-DZHK-24. It's an investigator-initiated trial in Germany comparing any approved catheter-based treatment tier, or TTVR, versus optimized medical therapy alone.
And the primary endpoint.
The primary endpoint is the tough one, a composite of all-cause mortality or heart failure hospitalization. That kind of head-to-head comparison focusing on hard outcomes is what we really need to confirm this sweet spot hypothesis.
And finally, there's this concept, especially in the U.S., called coverage with evidence development, or CED. How does that fit in?
CED is a really interesting pragmatic approach. When a new device like TTVI gets approved, often based on trials that enrolled relatively select lower-risk patients, CED mandates that centers performing the procedure continue to collect data, specifically on the sicker, higher-risk patients who might have been excluded from the original trials.
So it's about gathering real-world evidence on the broader population.
Precisely. It forces the collection of data on the all-comers, the kind of complex patients doctors see every day, not just the carefully selected trial participants. This real-world CED data is absolutely essential to understand the true impact of these therapies on mortality and hospitalization rates in the populations who might need them most, but also carry the highest risk. It will be crucial for shaping future guidelines. #tag conclusion.
Okay, so after this deep dive into the current evidence on tricuspid regurgitation interventions, it feels like we've landed on a few key points. First, intervening on severe TR, whether with TEER or TTVR, is incredibly effective at making patients feel better. The improvements in symptoms and quality of life, those KCCQ scores, they're consistently large and clinically meaningful.
Absolutely. That part is undeniable. The symptomatic benefit is huge.
However, that hoped-for benefit in terms of living longer, the mortality benefit, that remains much more elusive, doesn't it? It seems intrinsically tied to when you intervene.
That's the crux of it, the timing.
So the whole clinical focus seems to be shifting. It's moving away from just, can we fix the leak, towards can we identify the right patient at the right time?
Exactly. It's about earlier diagnosis, maybe using those advanced risk scores like the TRI-score, not just to predict futility, but to pinpoint that optimal window. Finding the patient whose RV still has enough reserve capacity to actually recover and benefit long-term once the valve is fixed.
Defining that ideal patient profile seems paramount now.
It really does. And that leads me to a final, maybe provocative thought for you, our listener, to consider. Given the clear evidence that a significant number of patients, maybe 20%, maybe more, can actually see their severe TR spontaneously regress with really good aggressive medical management alone.
Right, the regression conundrum.
And given the proven futility, the potential harm of intervening too late when the TRI-score is high and the RV is failing, perhaps the greatest immediate opportunity to improve outcomes for TR patients lies not necessarily in developing the next fancier device,
But where?
but rather in perfecting our ability to deliver early, aggressive, truly optimal medical therapy, including rhythm control when appropriate, and combining that with much more sophisticated data-driven risk assessment using tools like TRI-score and maybe future AI predictors.
To pinpoint that moment.
To precisely pinpoint that critical moment before the disease cascade becomes irreversible, intervening just then when the patient has the best physiological reserve to benefit, that might be where the biggest gains are waiting to be found right now.
The fascinating challenge focused on timing and optimization, not just technology. Thank you for watching The Funnel Effect.